very honored to be here and had a great time seeing your beautiful campus and catching up with some old friends. So this has been a wonderful day. So for my talk, I'll start by going over where we are in the state of things that we can try in humans with injured vocal folds for about the first half of the talk. And then for the latter half, I'll delve into some of the in vitro, some of the animal work that's been going on in my lab about where we might be looking into the future. But first, let me introduce this wonderful system that we have to produce our voices. I'm going to ask everybody just to take a deep breath and exhale. It was mostly silent, although I think I heard a sigh from somewhere over there. Maybe a yawn, I'm not sure which. But the point is that the larynx turns that silent exhalation, that silent airstream, into the sound source that we use for all of our vocal communication. So how does this happen? Really, at its heart, this is an energy transfer system. So we start with the steady airstream exhaling from the lungs that on its own would be silent, transfers that aerodynamic energy into the kinetic energy of the vocal fold mucosa, which moves, and we see this motion, we observe it on stroboscopy as mucosal wave. That allows the vocal cords to temporarily, momentarily store and then re-release that energy, again as aerodynamic energy upward, but now instead of being the steady exhalation silently that we all did, now it's the pulsed exhalation of a sound wave. And this happens without neurologic input, of course. The nerves just set the stage for the action, but the actual sound production does not require nerve input. It's all biomechanical. So there's the material properties of the vocal folds that allow this phenomenon to happen. So what are those material properties? For this coordinated mucosal wave and vibration to happen, the vocal cords have to be soft. And by soft, I mean, in a material standpoint, like kilopascals soft. So, we'll show you. I'll get to this in a moment. But if it's not soft enough, then we can still set them into motion, but it takes a lot more of that aerodynamic energy, right? And so we start to feel fatigued, and people don't like that when their voice is effortful from not being soft enough. They also have to be elastic, meaning after deformation, the vocal cords have to go back to their original shape. And they have to do this rapidly and repeatedly, 100 or 200 times a second. And it helps that they're symmetric, because otherwise if you have each vocal cord vibrating kind of on their own, then you don't get that good airflow, and it can be a very distracting voice, which we'll also hear an example of in a little bit. So to look more at what goes into those properties, here's a human vocal fold. This is stained in a pentachrome stain, which here at the 10x view is staining elastic fibers black. And this is kind of a yellow. The collagen fibers are stained in a saffron yellow. So first of all, we see that there's a lot of muscle underlying just this very small area of vocal fold mucosa. This is about 1 millimeter or 2 millimeters thick. And that's great for trying to replace this tissue, because it means it's small enough that you don't need to have blood vessels. So that's a real advantage. Looking here at the higher power, we can start to see the layered structure of our epithelial cells at the top. Superficial lamina propria, which is kind of a loose connective tissue layer that has some glycosaminoglycans in it. The middle layer is where most of these elastic fibers are, and then the deep layer is primarily collagen. And sometimes you'll see this referred to as the vocal ligament, which is the very deepest part of densest collagen. Okay. So to look in more detail at the mechanical properties of these vocal fold covers, so we started off just to benchmark the material properties by doing an indentation test. So basically you push on the tissue and measure the force that is generated within the tissue as you are indenting. There's a little puddle of saline around it, and here's our vocal fold. And we come up with around single-digit kilopascals as the stiffness of the vocal fold on this type of indentation test. Just to give you a framework of what that means, most plastics, even soft plastics would be in the hundreds to thousands range of kilopascals, so much stiffer than the vocal cord. As far as other body tissues, this is not as soft as brain. Brain is the softest. It's usually less than 1 kilopascals, but it's a little softer than like muscle and heart, which are more in the 10 to 20 range. So it's soft, not the softest, but pretty soft. Since then, we have upgraded the equipment a little bit, and so now we have this Bose biaxial tester where you can put a little chunk of, this is not vocal cord, although it could be. This is our tissue engineered cover, a little chunk of it on these pins, and you can cycle it to measure the forces that are generated from the extension testing. So we'll see a little bit of this data. Here we go. So these data are now generated from that biaxial extension test. And even though you see we have this big fancy machine and it's got 4 heads, so you could theoretically be stretching in 4 directions at once, practically we found that that's really hard to do in a reliable way. So everything that I'll show you is just the 2, so it's a uniaxial extension. And we'll start with, so we have here a stress-strain curve, meaning so you stretch out your tissue and measure the force that the tissue is generating in response. The red curve here is the human vocal cord in the medial lateral direction. So this is the direction of the mucosal wave. It is unconstrained in the opposite sides, and we see this is very, very soft. So we're only generating a stress we're going up to 50% strain, so that's stretching it out, half of its length is 50% strain. And at that, we're just starting to generate some stress, some force buildup within the tissue. This is very soft. If we constrain the ends, that would be this, the pink curve. This is a little more physiologic. You could now imagine the vocal cord tethered at the anterior commissure and posteriorly onto the vocal process, and now extending along the medial lateral direction. And here we see that it's still soft, but we can actually generate some stress within the vocal cords. So this is a little more physiologic. I would point out that 50% strain on the vocal cords, we don't really do that much, unless we're singing in a really falsetto voice. Most of our vocal function is more down here in the 0 to 20% strain range. And then I'll also point out the AP extension, which are these that are stiffer. So, for example, would be the constrained line. So definitely showing greater stiffness than the medial lateral. And you can understand why that would be when you think about the structure that we understand of the vocal cords, which has aligned collagen fibers along the AP direction. So if we're stretching in the AP direction, we're going to engage those collagen fibers, which are stiff. And we'll get more force buildup than if we are stretching in the medial lateral direction, which is basically pulling apart the collagen fibers. So much less stiffness in that direction. Instead, we're engaging the elastic fibers that are oriented transversely, and those are very soft. So we can conceptualize and measure these differences in vocal cord stiffness. This is just 2 human larynges, kind of just demonstrating that there is, of course, as we would expect, a lot of biological variability, that one larynx is not the same as the other, and that's one of the things that we have to be aware of. Okay. Let me show, of course, some examples of to ground you on the problems that I'll be discussing. Of course, a lot of carcinoma. This person will do very well no matter what treatment they have for treating their cancer, but their voice may not be as good, depending. I think there may be somewhat of an unpredictable voice, and so that's one of the things that we would like to make more predictable. Patient who's got bilateral vocal cord scarring, and then we'll also talk a little bit about the aging voice, which is a different situation than scarring, where here you have collagen deposition, and here it may be more of a deficiency situation. So to focus on that vocal cord scar caused by a number of things, long-term intubation can certainly do it. Injuries such as blast injury, inhalation injury, phonotrauma, especially if it's repeated, and severe phonotrauma. Radiation therapy, of course, is a big cause of vocal cord scar. Repeated surgeries, for example, in patients who might have papillomatosis and need repeated surgeries, even if each one is done very well. If you've had 100 chances, odds are good that you're going to have some buildup of scarring. Occasionally there can be congenital scars or people where we're just not able to identify the cause. These pictures were published a while ago from Hirano, but I really like them because they're about the only pictures that we have to demonstrate what happens in human vocal cord scarring. So these were both patients who had glottic cancers that were treated, this one with a surgical resection, this one with resection and radiation. And then later they had gone back and had biopsies to rule out recurrence. And so Hirano published these results, again showing some of the wild variability that we see among humans. So this is a stain for collagen in pink now. And we see just a little bit of collagen buildup here in this particular patient, whereas this one is, the whole vocal cord is basically replaced with collagen. So you could imagine that the voices are going to be different between these two persons, and our treatments also are probably going to be different. You would expect that there might be a lot of treatments that could help address this very focal scar, and when we're dealing with something where there is basically complete scarring, that's a much more difficult condition. So in general, what we think of as the changes that occur in scarring would be increased collagen, especially disorganized, so loss of that nice aligned collagen structure that we should see in the AP direction. The elastic fibers is really, there's not a consensus on this when you look in the literature on mainly animal experiments, which are all done in different ways, and maybe to some degree it's comparing apples and oranges, but there may be different presentations. Sometimes people discuss a loss of elastic fibers, but in other situations people have observed clumping of elastic fibers. So we'll keep that in mind as we go through this talk. Certainly loss of the hyaluronic acid from the SLP, and also some edema superficially. So here's an example of what I would call severe vocal scar, and we see very little vibration happening, if any, and the voice is, let's see if I can play this, maybe. I can't I may just let you imagine the voice.
Why don't you imitate it? Sounds like this. There you go. There you go.
Thank you. So what can we do for these at this point? Combination of some injections and some surgeries. So these are the things that I can think of that we might do to treat these patients other than voice therapy, which is kind of the first point for everything. So we'll go through each of these a little bit to describe what has been written about them. The fact that there's already a list of 5 possibilities kind of should clue you in that there's not really anything that's accepted and widespread by everybody. So steroids. This was actually a nice paper that came out a few years ago because they defined, first of all, they had a decent number of patients. They defined the population. Each one of these people got a single injection of corticosteroid. And I note with voice therapy. And I have this is supposed to be a double-edged sword here because the voice therapy is really good. So these patients got better. And I say a double-edged sword because voice therapy helps patients with scar get better, especially mild to moderate scar. So we help the patients in this study, but it becomes hard to sort out exactly whether it was the therapy or the injections.
And Jen, I was just trying to remember. They were all received the corticosteroid.
Yes, everybody received corticosteroid
So it wasn't
and therapy.
And therapy, right? I remember. Yeah. And so, what can we do for these at this point? Combination of
my takeaway from this is a good option for people with mild to moderate scarring, corticosteroid injection. You can't overdo it because if you are repeatedly injecting, then you do run the risk of atrophy, and that can be a very serious consequence. But for 1 or 2 injections is quite reasonable. Some of the other things that we commonly do. Medialization. This was another very good paper, a little bit older, but looking at now 3 different types of treatments, either type 1 thyroplasty or injection or a fat or fascia graft. And these were not randomized. These were surgeon's preference, which is pretty typical. They pretty clearly showed that the people who had the injections didn't help, injection medialization. And for the others, the patients felt better, but they couldn't really detect a difference. So this was kind of a landmark paper that many of us point to say, it's really hard to show that anything that we're doing is actually helping these people. Similarly, for fat or fascia grafting, studies are all small, retrospective, uncontrolled. Of course, many of them show that there is improvement. This was actually a nice one fairly recently with temporalis fascia. There are some risks of this too. I tend to not do fascia grafting. There are risks that it can extrude. It seems clear that the recovery time is kind of prolonged with this, and that there can be a potential worsening. So it may be one of these situations where you either can really help or perhaps really kind of go wrong with it. I think it's an interesting concept, though, because you are transplanting the tissue and some cells along with it. So the thinking is that this may stimulate repair of the vocal cord better than you would get from some of these other therapies. One of the simplest things you could do would be lifting up the scar, trying to undermine it, which again, small studies might help. So the idea of an angiolytic laser, I think, is interesting, and at first it seemed absolutely counterintuitive to me. Well, why would you laser the surface of somebody's vocal cord who has scarring? The thinking is that it is similar to lasering for skin, where you will stimulate the tissues beneath to regenerate, and there have been some animal studies that show matrix metalloproteinases increasing in this situation. So this is an interesting, but again, small study. So the status of where we are is that there's a lot of things that we can do, and it's basically based on surgeon's preference, what they're comfortable with, and in that particular situation. And what I typically tell patients is there are some things we can try, but the results can be unpredictable with all of them. So, hence the interest in some emerging treatments, such as growth factors or therapies. The growth factors are primarily in Japan and Korea. There's 2 that you will hear about: basic fibroblast growth factor and hepatocyte growth factor. Again, all of these are uncontrolled studies, yet showing some improvement, especially for the mild to moderate scars. And we at least can have a good theoretic framework for the mechanism of how these growth factors may work. For example, FGF is known to increase hyaluronic acid synthase, which is a good thing, right? And interestingly, then, FGF also increases other growth factors, such as hepatocyte growth factor, which again increases HA and can have some of that effect on MMPs. So I think this is a really interesting area. Neither of these is available in the United States at this point, so it's still a little bit of an unknown. Yeah.
A quick question, but I think the use of growth factors is interesting because the 2 scenarios that you put up, I mean, presumably the really terribly scarred vocal fold may not have the responsive cells that you want, right? Like you have more myofibroblasts. So like, you know what I mean? You could put growth factors in there, but they're just not going to cue the same way. So, I mean, is it also that the easier stuff is easier to treat even if you do this? Or if you've got real advanced disease, it'll still respond to growth factors?
Yeah, that's a great point. And most of the studies are saying mild to moderate scars rather than the severe scars. And that may be one reason why it is hard to treat severe scars, that you have the resident cells have altered their phenotype. we also have to think about, I think, the half-life of these pharmaceuticals, which is going to be short. So how much change can we get from a single injection? There's some interest in reformulating the growth factors into like a sustained release, which would give you at least a longer-term benefit, but still a fairly temporary action unless you're able to do it really early on and shift the pathways of those resident cells to prevent them from going down a myofibroblast phenotype pathway.
Jennifer, I have a
Yeah.
question. We've heard about hepatocyte growth factor in Japan for a long time, and they've reported, interesting results, especially in the elderly population with presbylarynx. But do you know what has been the barrier for the FDA approving hepatocyte growth factor in this country? What is it about it that we're not seeing it in use over here?
Yeah, that's a great question. I don't know if it's the FDA or that there hasn't been a company to champion it, which is, the voice field is kind of relatively small as far as markets go. And I think that a lot of the companies may be a little bit gun shy of investing in this area. You could imagine it's an area where you could have kind of if you had bad results, it would look very bad potentially. That's just my thought. But I'm not aware of any companies that have tried to put forth these growth factors into a clinical product. Certainly the FDA hurdle is substantial. I think it's an important hurdle because it is there to protect patient safety and to make sure that there is actual data supporting our treatments, but it takes a big commitment from a company to go through that. There's a couple that are not even tried in humans anywhere yet. There's a lot of interest in antifibrotic drugs, such as this one that is clinically used for idiopathic pulmonary fibrosis. So that's something where we could potentially start to see off-label use in the vocal cord. If there was convincing evidence, there hasn't been anything done yet that I have been aware of. And then always interested in materials, such as taking cadaveric vocal cord, grinding it up, and injecting that. Certainly there are growth factors that are present in that type of a formulation or other formulations, but these are also not yet in humans, so I won't talk about that too much. I will talk a little bit more about cell-based therapies, and there's basically three kinds that have been reported, or that we know of as being done in humans. So the first is mesenchymal stromal cells. These are from bone marrow. This was a clinical trial done in Sweden that has not been published yet, so a lot of interest in this therapy based on animal work, but we don't know yet what the outcome in humans is. Also, this I will note, this study did not have, as it was proposed, did not have a control arm. Stromovascular fraction. So this is basically liposuction. You take liposuction and separate the fat, separate the red blood cells. In between, you have a layer of fibroblasts and some adipose-derived mesenchymal stromal cells, which are used in lots and lots of clinical trials for lots of different applications. So this particular clinical trial used that stromovascular fraction, which contains the adipose-derived mesenchymal stromal cells. Interestingly, they published one of their 8 patients that was a lot better, but I don't know why they didn't publish the other 8, so that's a very interesting development. So can't really say too much about this either, and again, no control arm. So I will spend some time talking about this one, the autologous fibroblast injection, which, let me introduce here. So this trials have been published. The phase 1 was done at UCLA. Again, a very small, uncontrolled study, as is typical in the field. Showing some promise. So then this progressed to a phase 2 study, and lots of names here in this room, so it's exciting to have a bunch of people together. So this study was really interesting in that it actually was a multi-center trial, randomized, which means controlled. So there was a treatment arm and a control arm. These patients all had a skin sample harvested from behind their ear, sent off to the the fibroblast company that dissociated them sends us back cells, and we injected the cells in the vocal cords. These were autologous dermal fibroblasts. We included patients with both scarring or age-related atrophy. 21 patients, which was smaller, but kind of in the line with a lot of things. 15 injected and 6 controls. We actually were aiming for a 2-to-1 randomization, which would have been more like a 14-7 outcome. But we had, one person drops out, and the randomization is a little bit off, and so the numbers didn't quite turn out as I would have liked. Each of these patients received 3 injections in the office, awake, in each vocal cord that was involved. So for some people, if there was scarring in just one vocal cord, they would only get a unilateral injection, so 3 visits, 1 month apart. Otherwise, if they had both vocal cords involved, they would come for alternate injections, 1 at a time, so up to 6 visits. And we did these as 1 vocal cord injected at a time, just because the volume injected was about 1 cc, which is a pretty sizable volume in the vocal cord, so you do see quite a lot of ballooning of the air, so we didn't have any airway events, and indeed there were minimal adverse events. Some people had some ear pain temporarily afterwards, cough temporarily, so kind of minor things. So what we looked at in this study, basically break it down into 3 areas: the mucosal wave, what we thought of their voice, and what the patients thought of their voice. So I'll also, again, point out this was blinded, so the clinicians didn't know who was getting cells or who was getting the control injection. We rated the most mucosal waves on a 1 to 5 scale, and actually found that in the injected patients, mucosal waves all improved at 4 to 8 and 12 months. This is after their last injection. So for example, they would come in monthly for injections for 6 months, and then we followed them for 4, 8, and 12 months after that. So this was a long study. And found improvement in mucosal waves in the injected, but not in the control patients. So that was encouraging that our blinding was actually blind. There was not a difference, however, between the injected and the control patients at 12 months, which is a little bit of a confusing result there. When we look at how we thought their voices were, again, blinded voice ratings, and we tried to, we listened to voice samples and tried to generate a consensus, which was also hard to do. The outcomes of our voice ratings were, again, that the injected patients' voices improved, but not in controls. And this did reach statistical significance, scarring versus controls at 12 months. Interestingly, not at 4 or 8 months. So you might think that maybe the cells took longer to have their effect, that it was kind of a slower response. And that was the opposite of what we saw in age-related atrophy, where the voice was better in those patients earlier, but then was not sustained out to the 12-month mark. So I think this finding highlights that these really are 2 different disease processes and behave differently. And then finally, the patient-related voice measures. So VHI, we asked them, is your voice better, the same, or worse? And we asked people to rate along this scale, where are you now? If you compare your voice today to before treatment, this would be the best possible voice outcome, and this would be the worst possible voice outcome. And the scars, the patients with scar who got injected, they averaged out kind of around here. So this was an encouraging finding that the scar injected patients felt like their voices were better. There's of course some recall bias in this because you're asking the patients to remember what their voice was like before they started treatment. But nonetheless, we didn't see that in controls.
Jennifer, why didn't you record them pre and post-op?
We did record them, but we didn't play them back to the patient when they were determining this. That would be an idea, a possibility, yeah, to play today's and last month's or before treatments. that gets into the issue that nobody likes the sound of their voice. So you'd have to play both, the before and the present. Otherwise, they would all say that they sounded horrible before. Okay. And so in response to that question, do you think your voice is better, the same, or worse? I think this is an important finding. In addition to the numbers on that scale, SCAR patients, 7 out of the 8 at 4 months thought that their voice was better. One actually felt like it was worse, and this person apparently dropped out because by 12 months, we only have 7 patients here, and they all thought that their voice was better. So that attrition of patients is a problem, of course, with clinical studies. And we saw similar things in our controls where, you lose one control and your numbers can be skewed quite a lot. So overall, I felt like this study was encouraging, but certainly not the solve the debate to the extent that we were all hoping that it would. And so I think it brings to mind there are a few different types of challenges when we're dealing with studies like this. One is the methodological of how you do these studies, and then, of course, there's the physiological. So to break these down a little bit, all of these studies are small. We didn't mean to do an underpowered study, but when we actually looked at it, we were powered to detect a difference of are you better in 80% of the treatment to only 15% of controls? So that would be a slam dunk if we were able to generate a difference like that. And we didn't. So the controls had a pretty high placebo response. By the end of the study, half of the controls thought that they were better too. So that is a challenge and unfortunately requires more patients to be able to do that kind of study. This discord between how we rate the voices and the VHIs that did not improve is also disturbing, and that is, I think, common to voice care in general, that often we find patients are coming in still having voice complaints and still, rating high on their VHIs, even when we think that, to our expert ears, they sound better. I think the populations, I think it really helps to define them very carefully. This is always a complaint that none of our outcome measures is perfect. We don't have anything that is truly reflecting the physiology. And then, of course, there are some physiological challenges, too, such as, we don't know how long the cells are lasting and being active once we inject them. We don't know how much they're remodeling the ECM, and the fibroblasts we wouldn't expect would be doing anything to modulate the immune system, and maybe that's a really important point. So regarding these physiological limitations that it's easy to look at the study and say, wow, it's hard to do voice research, but there may be some underlying physiologic reasons also why we didn't get a robust response, as robust as we would like, and that could come down to these physiological issues. So a couple points about those. First, I think animal models are a really great way to get at these questions that in humans we're only guessing at. So a plug for doing good preclinical research. And second, when we think about how to optimize each one of these factors, it becomes clear that maybe an injectable therapy that is administered and then may go away may not be the best way to produce the greatest effect looking at these outcomes. So if we want to think about what ideally we would like in a therapy, our goals would be to get rid of whatever isn't working, and that could include the cancer. Maybe we just want to remove that cancer and then be able to restore a functioning vocal cord after that. Or it could be the scar tissue. We would like to have something temporary there that will organize the vocal cord to repair itself in what would become a native mucosa, because none of us wants to have a Teflon injection or something that's not going to be recognized as native. So ECM repair is the norm or the goal. It's got to be able to prevent scar tissue from happening again. Otherwise, as soon as you treat it, you're going to be back where you started from. And you need to have, getting at your point, you need to have introduce the cells or modify the cells that are there to have long-term healthy maintenance of the vocal cord in perhaps a patient who may not have those healthy cells to start with. So with these goals in mind, that led to the work that has been ongoing in my lab for a number of years now on the cell-based, call it the cell-based outer vocal cord replacement, or cover, intended to replace the vocal cord cover, the mucosa and lamina propria. And here we see the implant after 2 weeks in a rabbit model. So the approach that I've taken to this implant is to mix fibrinogen monomers with adipose-derived mesenchymal stromal cells. So these are the MSCs from liposuction. If we culture them for a couple weeks with, very importantly, an air interface and epidermal growth factor, then we develop this, this three-dimensional tissue with an epithelial-like layer on the top. I chose the adipose-derived stem cells because they're easy to get. They could be autologous. They do have some immune modulatory function in addition to their known differentiation to the mesenchymal lineages. And they're used for a lot of investigational things and no actual therapies at this time. And here's what we see when we put these cells in fibrin and compare with the vocal cord. It's okay. So fibrin I chose, again, because it can be autologous. You can extract it from a blood sample. The cells grow in it very well. So unlike some polymers that don't have really good cell adhesion properties, it is soft, like we talked about, yet you can handle it. You can put a suture through it. You can pick it up. It is, in comparison to a collagen hydrogel, it doesn't contract as much. So it does not have that tendency to become stiff and to shrivel up that, if any of you have worked with collagen, you've probably observed. And it is resorbable. So it solves that problem of, we don't want to have our implant lasting forever necessarily. And so looking at this culture system, we see that we get a rudimentary epithelial-like differentiation of the cells at the surface. And I would not claim that they are epithelial cells, but they do express some epithelial markers, such as E-cadherin, whereas the cells further down within this structure expressed by mentin, which is a mesenchymal cell marker, similar to what would be expressed in the vocal cord. This is at 2 weeks of culture. It's not a mature epithelium. There are no, junctional proteins there. There's not a barrier function, but it's some of these marker proteins. We also see that there are differences in the collagen deposition of the ideal case versus what you would call a control or a homogeneous case, which is where you just put culture medium on top of it. And in that situation, you get a lot of collagen deposition right at the surface, which is exactly what we don't want in the vocal cord. So rather, having some type 1 collagen deeper within the structure is more what we would hope to achieve. We also know that in this system, the mesenchymal cells are not differentiating to that myofibroblast phenotype. They are not contracting. So here we have our EGF-treated ideal group, very little myosin or procollagen expression. It actually goes away even more with culture time. Same with smooth muscle actin. As opposed to traditional culture, where still within the gel, but not treated with EGF and at a submerged interface. So those culture conditions really matter in maintaining this quiescent, non-activated phenotype. And when we measure, back to the indentation now, when we measure the modulus of our gels, the ideal conditions, we are still in the single-digit cover, as we are with the non-ideal conditions, but there is a little bit greater stiffness, as we would expect, from that activated phenotype. And then looking at the extension testing, here was the human vocal cord graph we looked at before, and now we're looking at, in the red and the blue, 2 of our gels, the idealized gel, again, a stress strain curve, and the scales are different here, so here we are going up to 12 kPa, and maybe it's easier just to look at this. Here we have a Young's modulus of 8 kilopascals at the 20% strain, which is a physiologic strain. We've done some experiments where we produce this gel and then remove the cells, treat it with the treatment, and eliminate all the cells. So then we are left with the mature matrix, but not the cells within it, and have tested that the stress strain behavior in that situation is close, reasonably close to the intact case. We'll talk a little bit more about that issue. So what happens when we implant these things? So I started using rabbits as our model, and the reason for that was mainly size-based, because anything smaller, it's pretty hard to do a vocal cord implant. Yet I didn't think we needed anything bigger for this type of work. So this is an eye instrument used for cataracts that works really well to remove the vocal cord cover. So this is a rabbit vocal cord that is removed. This is done in an open surgery. And we looked at 3 different conditions. One would be that gel, the cover. And I say allogenic, so this is using rabbit stem cells, but not from the same rabbit. So different New Zealand white rabbit cells. Versus what I thought would be kind of the ideal control, which is the perfect condition to start with. So we have a perfect vocal cord tissue. What happens if we implant that? So that would be the actual vocal cord. So we looked at this, where if you remove the vocal cord and then put it back down, suture it in, it's got everything in there, right? It's got the perfect extracellular matrix. What happens in that situation? We can't make anything better than that. So what happens? And then scarred control. Let these go for a month and see what happens. So here's again our vocal cord cover that we're starting with. Has some elastin, has some collagen. Our gel cover that we're implanting doesn't have either one of those things at 2 weeks. It's very bland. So that's our starting point. And when we look after 1 month in these 4 conditions, here's a normal rabbit vocal cord. It looks a lot like the human one. In the scarred case, we do see some edema here at the surface. Here's our cover replantation. So pick it up, put it back down, suture it in. And here's our gel implant. H&E you can't really see very much on any of these. So we'll look instead so here we can compare the cover implanted versus the contralateral side. I was only doing 1 vocal cord implant because I was scared to do both, because I'd never done these before in rabbits and thought that they might all obstruct, which they didn't, fortunately. But we could also compare the normal with the implanted. There might be a little bit more collagen in the blue on this one, maybe. And this was a really interesting image, I thought. This was an implanted vocal cord where we just happened to catch this elastic tendon at the anterior commissure. So we see very clearly strong elastic fibers on the normal side and very clearly not present in the cover implanted side, which is not surprising. We know that elastic fibers take on the order of months to develop, so I wouldn't expect that we would see elastic fibers at this 1 month time point. And here we look more at the elastic fibers in the normal. It's a nice transverse elastic fiber here in the black. And we see something interesting, I think, in the scarred and in the implants, which is we're not seeing these nice fine transverse elastic fibers, but we're seeing these black clumpy fibers that are within the deep layer. And in the cover replant, we also see a lot of these. Here's maybe some nice normal ones, but then also a lot of clumpy ones. So that I thought was kind of interesting. In our cover, we don't see either. So we don't see clumps, we don't see nice normal ones. But it raises the question, I think, of if the elastic fiber clumps are part of the problem in scar. And you remember when I said about what happens in scar, and there's a lot of discord on this issue of elastic fibers, if they're present or if they're not present, or if they're clumpy. We do know that in skin, for example, if it's gone through photoaging, the elastic fibers remain but are clumped. They are very slow to degrade in the body. And it may be that the presence of those injured elastic fibers that can't be degraded is impairing the production of new ECM. So that's part of my, haven't proven that yet, but that's one of the working ideas that I'm going with, in which case having a system where you remove all of those cloned elastic fiber would be beneficial. We also looked at a special stain for the fibrin scaffold, and it's supposed to appear blue. We do see some kind of bluish fibers here. This is a suture, so we know we're right at the edge of our implant area. And this was after 1 month, so a little bit of the fibrin scaffold still present at 1 month. We did a subset of rabbits where we implanted male rabbits in male cells into female rabbits and did an in situ hybridization to look for the Y chromosome, and indeed see that there is Y chromosome presence in the left side that was implanted but not in the right. And that was confirmed in all 4 of the animals that we tried this on with PCR. So at least at 4 weeks, there are some cells persisting. I can't tell you how many are persisting, but there are some, and they appear to be present both in the epithelium and the mesenchymal layer. So we also then can look at the vibration of this system, of the larynx. So here's our excised larynx system, where there's a teeny tiny little rabbit larynx down here mounted on a pipe that's got humidified air coming up from below the table. Some lights, some microphones. We have a high-speed camera pointed right on the top, giving us this view of the rabbit larynx. And when we put a suture just to adduct here in the back and allow air flow through, we see some vibration. And we can take those sequential images, draw a line through it, and present those images as a time series of timography. This is a way to condense all the huge amount of data that one gets from high-speed video. So now we see the vibration of the normal vocal cord down here on the bottom and the injured vocal cord up here on the top. And they are coming together at each glottal cycle and then opening. And when we look at this chymography for each of our conditions, we see that the scar, of course, looks horrible. This is the scarred one that's really irregular, but even the normal one looks bad because it's not able to have organized vibration. When we put in the perfect vocal cord cover, as good as we could get it, it's got everything there, normal and implanted. So it's better for sure, but it's not symmetric. So there's still a difference. And finally here it would be our cover where we do see symmetry, and in fact the cover animals were the only ones that achieved symmetric vibration in the system. So our conclusions were that after a month at least, these implants, the cells were surviving. They could phonate for short periods. Cells were still there, they were symmetric, and yet we don't have elastic fibers at a month. So that led to the next phase of work, putting rabbit cells into humans. I'm kidding.
We want to see if we're paying attention.
Yes, I'm seeing if you're paying, exactly. So the last experiments I presented were all rabbit cells into rabbit. So not autologous, but allogeneic. So now I wanted to step a bit closer to what the actual human translation would be, so therefore using human cells. So this next series of experiments that's ongoing uses human adipose-derived stem cells, but again, looking at a rabbit model. And this is ongoing. We're looking at a few groups here. One is the cover, now with human cells. We're also comparing it with just injecting those cells. So removing doing bilateral vocal cords this time because I'm now braver and it's good to get more tissue to work with. So bilateral, removing the entire vocal cord mucosa and then either implanting our cover on both sides or injecting cells on both sides or implanting that acellular scaffold that we talked about where we start with the scaffold, let it mature, and then extract all the cells, and versus a scar. The reason that I'm doing all these 4 groups is because if we could do something simpler, that would be really great. If we can get just as good results with a cell injection as with doing this whole implant thing. That would simplify it. Similarly, if we can not put in cells at all, but if it's just this fibrin scaffold that's acting like a bandage and that's helping, that would be great. Those would be much easier to translate. So we're looking at those. And this time letting them go out a little bit longer, looking at the wound healing, the immune response, importantly, and also in the long-term ones, what happens with the extracellular matrix. And this is ongoing, so I don't have a lot to show you, but I will show you now looking at HLA expression as a marker of our human cells. And we found that in all of our cover implants, we actually have a lot of human cells persisting. And similarly in the cell injections, a lot of human cells persisting. With the controls where we are not, where we're doing the appropriate immunological controls that are totally negative, and of course the D-cell gel and also the scar also negative. So this is interesting. We had expected, based on our previous work, that the cells within the cover would survive. I was a little surprised to find as many of the injected cells surviving as we did, because injecting is kind of, you're taking them out of their usual niche. Often cells don't do well in that situation, but apparently in our case, this has worked out okay. And then I want to talk very briefly about our final xenograft model, which is now moving into pigs. So this is a pig larynx. You can see much easier to handle than the little rabbit larynx here. And the reason we're doing this, again with human stem cells, is to step towards that translation in humans by scaling up to a reasonable size. And very importantly, the pig is a voicing animal. The rabbits are great for voice rest, but not great for really, measuring what their voices sound like.
Yeah.
So this also is ongoing, but I want to share some early results with you. First of all, most of you probably haven't heard normal pig squeals very much, so here's a normal. That's a healthy pig and has had nothing done to it. And we see on the spectrum, it's got a lot of these high-frequency formants. Then we take one vocal cord off, implant the cover. This is 2 days afterwards. Sounds awful. I mean, really clearly a difference, right? And when we look at the spectrogram, you can see that difference as well. By 10 days, it's starting to recover already some of those high-frequency formants. Not there yet, but getting a little bit better. And then by 30 days, it's a very short sample. I don't have a great 30-day sample. Sorry, it's short and quiet. But we're, again, recovering some high frequency. So these animals we're going to keep for 6 months, and then look at the vibration at that time. So we will be hopefully getting more information about the long-term properties in this system. So to wrap up, for the problem with vocal cord scar is that the lamina propria, there's nothing else like it that we can just put in. It's hard to repair it. The treatments that are out there really don't do anything to address the actual problem. They are trying to work around the problem. So all the emerging treatments, even the growth factors and the cell injections, are actually at least aiming to repair that abnormal structure. We talked a little bit about fibroblast injections that had some positive benefit, especially in scar but not atrophy, and then introduced this implantable cover that aims to provide a new cell population along with better ECM to actually restore the function. And I would like to acknowledge our funding sources, and there have been a lot of people that have helped with this project, including in this room. So I'd like to thank all of you all as well. Yes.
I want to congratulate you on an excellent scientific model. That's fantastic.
Oh, thank you.
I thought of a clinical application at the very beginning with your strain gauge when you were measuring how much resistance. When you do vocal cord medialization and you have to know where to tie the suture, that'd be a great way to do it when the patient's asleep and rather than wait on their voice. Is there a clinical application for doing that?
There's not. We have, I know there are some investigators working on a contact, like optical coherence tomography probe that can measure strain within tissues when a person is anesthetized. So in the situation you're proposing, they could be asleep, and then you pass the probe and
Your
stop
anterior,
the
posterior thing that you're talking about, yeah.
Yeah, very interesting. Thank you. Yes, Yue.
Any thought on what the elastic fibers, like in that 1 month histology, there's like no elastic fibers, but any predictions of what's going to happen, since you mentioned that the clumpiness might cause some of the issues?
Yeah.
I wonder what that elastic fiber is doing over time in your model.
Yeah, I know. I'm really looking forward to getting those long-term data also. We know from other model systems that it takes a couple months to produce elastic fibers, and that happens in humans too. In our development as infants, we're actually born without really much elastic fiber in our vocal cord, and those develop over time as we cry and use our vocal cords. So I think in that sense, we may have better results looking at the pig model, where it actually is using the vocal cords and applying this mechanical stress to it, as opposed to the rabbit, which kind of just sits there. You know, a lot of tissue engineering is sort of this combination of setting the signals and then also supplying some therapeutic stress, which in our situation would be the voice. So the key is to have enough voice to allow development without having so much that you kind of just blow the thing off early. I initially was thinking about giving some Botox to the pigs to put them on voice rest, but they didn't rest even with the Botox, and then it complicated the voice analysis, so we're just letting them be and hoping.
And one last question.
Yeah.
What do you think about PRPs, like platelet?
Oh, yeah. Thank you so much for asking about that, because I was thinking about adding that to our slide of autologous therapies, adding platelet-rich plasma, which is not exactly a cell therapy, but it's a autologous derived source of growth factors. And I didn't include it because there's nothing that's been published about it in the vocal cords and no trials that are ongoing. I would love to see some data from anyone who's doing it. But yeah, theoretically, that's kind of a growth factor soup. So the advantage of PRP is that it is easy and it avoids any of those market issues and FDA clearance. I would be personally hesitant to use it without having some data first. Clearly I like data, and I think animal models are a great way to get that. But that may kind of get around some of the growth factor issues of availability.
You gonna do it?
The machine is there in plastic clinics, so I don't know. I'm trying to ask that.
Yeah.
That was a great talk, and it was really nice scientific explanation of a very difficult problem. But I was curious, you mentioned in the beginning, but have you thought about adding protease inhibitors into the mix in order to prevent the remodeling or reduce scarring and keeping it soft?
Protease inhibitors in the gel that we're constructing, or?
Yeah, like, or into if you were to inject some kind of growth factor mix, inject in that setting, or with a filler, like if you submit a filler in there, maybe do to prevent sort of recombination, or sort of prevent scarring and tightening.
Yeah, so a protease inhibitor you would not be able to clear out any of the existing scar, would be, I think, the problem with that. Having some matrix metalloproteases that are able to degrade the scar, I think, is beneficial to kind of clean up some of the collagen. If you were thinking alternatively about putting it in with a filler, the filler would probably last longer, but then that would kind of presume that we were getting good results initially and trying to extend those results. I'm not sure that that's the case. Yeah, there's a lot of different conceptions that you could use to try to treat these things, and it's hard to know exactly which one is going to be the best.
Very good.
All right. Thank you, everybody, for
Excellent.